This is part 3 of the Instructor video series on prevention and crisis services, and we're going to now move into talking about what are the specific guidelines for training that came out of those political advocacy efforts from 2001 to 2012. And then in 2012 there was a call for this task force to develop these guidelines, and those were published in October of 2014. So haven't been around for that long, these real specific guidelines. And what the task force found was that while a lot of mental health professionals, such as social workers, psychologists, psychiatrists, counselors, and psychiatric nurses, encounter individuals at risk for suicide, many of these mental health professionals actually lack competence in addressing suicide. So what the task force sought out to do was to get a broad perspective on the current state of education and training for suicide, and then to draft a set of guidelines about how to better train the workforce. And to take a look at how attention to suicide training has evolved in counselor education requirements, we'll look at CACREP's standards. And we know that CACREP is the accreditation body that sets national standards for counselor education and training. Every couple of years, CACREP goes through its own revision of its standards to update the requirements for the education and training of counselors. So this slide shows you how suicide was mentioned in the 2001 standards. And the first bullet shows that it's really just kind of lumped in with conditions that could possibly affect older people. And then the second slide here is it's thrown in as a condition that could affect students, so mainly for school counselors and those working with gerontology. Definitely not a lot of real specific attention given there. Then in the 2009 revision, we get some very specific references for suicide prevention and how to use specific strategies, a call for counselors to really be able to demonstrate the ability to assess and manage suicide, some screenings related to suicide, and how specific problems and interventions can influence family life related to suicide. In 2016, those standards have already been published, and they take a more broad perspective and allow each program to develop its specific guidelines. And so it includes everything on the previous two slides from the 2001 standards to 2009 standards, but says it in just a much more broad and efficient way that counselors need to have knowledge of suicide prevention models and strategies, and need to be able to demonstrate skills to use procedures to assess for the risk of aggression, danger to self, danger to others, and suicide specifically. We know that the best practices when dealing with a person who is experiencing suicidal ideation or a suicide crisis is to really rely heavily on the counseling relationship. We know that there are some specific risk factors that increase the likelihood that someone will experience suicidality and that they will actually complete a suicide attempt. So you can pause and read through all of these. Many of them you're already familiar with, but some of them might be new to you, such as the very last bullet, the suicide cluster. And this refers to when, for example, in a school, let's imagine a high school, one student completes suicide and then 3 or 4 other people in close proximity of time end up completing suicide at the same time. And that's because there is this element of contagion that when one person experiences or completes suicide, that those in their world and their circle become more vulnerable and at risk of completing suicide themselves. So while there are certain risk factors, there are also protective factors that help to create a buffer between an individual's likeliness to experience suicidal ideation and to make an attempt and to complete a suicide. These are all factors that we would want to work with our clients to we want to assess for these factors, and we want to really promote these factors because they will. This is like if you think of the analogy of exercise, that if you want to have a stronger back, you need to not just focus on your back, but build up good abdominal muscles. So this would kind of relate in that with suicide, you don't just want to think about eliminating the risk factors, but you actually want to strengthen things on the front end. So you want to strengthen the protective factors. You want to build up your abdominal muscles so that you have a strong back. I hope that analogy works for you. We also need to be really cognizant of our duty to protect and warn when it comes to safety. And this means that if our clients are not forthcoming about their suicidal ideations, if they're being vague, then it is your absolute role to try to elicit them to be more specific, to be more concrete, to be more expressive about them. And you do that by asking really good pointed questions. Documentation is a really critical issue when it comes to suicide and any type of crisis. This slide tells you some specific things that should be in your chart or your clinical records when it comes to working with someone with suicide, and you can pause and read through these. Some do's and don'ts, again, as related to documentation. Some other things that you want to consider are if a person is hospitalized with suicide and then they come back into your care, that you want to think about the follow-up and document the follow-up treatment. And you also want to think about help them with a transition. So if they're hospitalized and then they're returning to their college residence hall, then working with them on what that transition would be like, what they're going to tell people about where they've been, what to do if they experience suicidal ideation again. And then the other things on the slide that I'll highlight would be the unique factors about the culture of your client or the local community in which your client is working in. Some communities have a real painful legacy related to suicide. Other communities, stigma might be higher. And then related to that, there's certain demographics of specific populations that or demographics within specific populations that are going to put those individuals in a more high-risk group. So you want to make sure that you're aware of those and that you're kind of upping your assessment level when you're working with individuals from those populations. An example of when you would need to breach confidentiality for the sake of a client could be such as when a client calls a suicide prevention hotline and they're by way of calling the suicide prevention hotline, they know that the person on the other end of that phone is in the role of preventing the suicide. Yet that client on that caller might be saying, oh, please don't call the police and tell them that I'm suicidal. But that's actually the role of the worker. So even though the client would be specifically asking to just have the phone call with the suicide prevention worker, that suicide prevention worker would have to breach confidentiality, call the police, because that is their job. And on some level, that client calling the suicide prevention hotline knows that they are opening themselves up to an intervention because they've actually reached out to a suicide hotline. Okay, let's talk a little bit more about doing the actual assessment and responding in a kind of first aid way to suicide. This slide highlights some of the things that you would want to talk about with your clients, and we'll go into more detail about these. You can read through those. A key here is that you're going to have very open and direct communication with your clients about everything related to their suicide, much more so than you might initially have the comfort level to do so. But you're going to have very open and direct conversations with your clients about the nature of their thoughts, their plans, their intentions to act on those plans, whether or not they can access any of the lethal means, whether or not they're experiencing pain, and is that pain unbearable? Are they isolating themselves from resources and people who could help them? Have they ever had a prior suicide attempt? Have they ever been exposed to suicide through media, through family members, through people in their community? Do they have mental health issues? And what are their patterns of intoxication? How likely are they to get drunk or high? How likely are they to be around the lethal means to suicide when they are drunk or high? And the key here is the open and direct talk. Sometimes people think if they talk about it, then they might increase the person's likelihood to carry out some of these actions, or that they might be planting an idea in the person's head that would make them more vulnerable. But as a mental health professional, you want to have those really open, really frank conversations. You want to ask about, under what circumstances would you actually act on those thoughts that you're having? You really want them to be able to identify that so that you can come up with a good prevention plan, so you can do a really thorough and accurate assessment. And while you want to talk about all the negative things, you also want to talk really open and clearly about those protective things. What is a client's reason for living? Why do they get up each day? Why did they get up yesterday? Why might they get up tomorrow? What is keeping them alive and being in your office right now? What might keep them alive in the future? How connected are they to individuals, family members, community members, online social groups, people that they interact with through social media? Who is it that they are, their church community, or maybe a group that they're a part of? Who is it out there that might miss them when they're gone, or might be impacted by their death? Supportive relationships with healthcare providers, and then what kind of an active role they plan to take in their treatment. You do want to work towards coming up with a safety plan, which would mean that they agree for safety, that they would go home and either remove or disable those lethal means, that you would connect them with emergency resources, such as passing out a card that would have a suicide hotline, the local 911, the crisis intervention line for your particular mental health agency, which could be a local suicide prevention line or a local crisis team, or it could be you and other counselors in your practice sharing on-call time. And then you also want to come up with some real specific ways that at-risk individual can increase their connectedness to others in their lives and start to engage in some protective activities. So some groups that are more at risk for suicide, and when you think about suicide, you really want to think about this continuum of thinking about it, planning for it, making an attempt, which could be one, could be multiple, and then the actual death. Among young people ages 15 to 24, suicide is the third leading cause of death, and among American Indian youth, it's the second leading cause of death, so more than accidents and homicides. There are more than 2 million attempts each year and 2,000 successful attempts. Girls and women tend to have more attempts, while men and boys tend to have more completed suicide. American Indian and non-Hispanic white females have the highest rates of suicide attempts of all females from any racial and ethnic group. The highest suicide in the United States is proportionally, this is a small percentage of the overall population, but within their population there is a higher rate of suicide, would be among American Indian boys and men, followed by white boys and men. That being said, African American males are up 200%, so they represent the greatest increasing rate. The highest rate of attempts among any groups would be Hispanic females, and if you think back to that case note of the primary care physician, what a missed opportunity that was. In North Carolina, we lose one teenager a week to suicide. So we really want to make sure that we take all references to suicide seriously, including thoughts of just wanting to die, feeling like a burden, being hopeless, engaging in reckless behavior, withdrawing, experiences of rage, revenge, and extreme mood swings. This is the QPR method that I talked about earlier. You definitely want to not phrase questions in the form of, "You're not thinking about suicide, are you? You don't really want to die, do you? You're just kidding, right?" You definitely don't want to phrase your suicide assessment questions in that way. And you want to teach parents and others not to ask those questions in that way also. Here's just some startling statistics about the high school situation I encourage you to read. The idea of rational